morning. On behalf of UGCR Organizing Committee, I welcome you all to 8th edition of UGCR. Respected Emeritus Chairperson, Mahatma University of Medical Sciences and Technology, Dr. M.L. Swankar sir, Chairperson cum Chancellor, Dr. Vikas Chandra Sharankar, Vice Chancellor, Dr. H.L. Gulati, Pro Vice Chancellor, Dr. V.K. Kapoor, Principal Mahatma Gandhi Medical College and Hospital, Dr. N.D. Soni, faculty members and dear students. Today's our topic for UGCR is Diabetes Mellitus. As this was a big topic and very important topic, so it was covered in two parts. Part 1 was completed in 7th UGCR and which covered anatomical, physiological, biochemistry and the pathological aspects of diabetes mellitus. And in this part, we shall cover clinical features, management, prevention or preventive aspects of diabetes mellitus. As per format of UGCR, it is prepared by our undergraduate students and presented by our undergraduate students, prepared under the mentorship or supervision of the HODs and moderators of different subjects pertaining to that particular topic. Then it is reviewed by our board of review and then finally presented by the UG students of different phases. So now it's over to our first speaker, Dr. Aru Jain. Dr. Aru Jain.
Thank you so much, sir. Good morning to respected dignitaries, teachers, and my fellow colleagues. Today, I, Aru Jain, am going to represent Pharmacology department on the pharmacological aspects of diabetes mellitus. I am going to present on behalf of my team of Praveen Kaur, Radhika Srivastav, Aman Kumari, Zainab Pawar, under the guidance of Dr. Anusha Vora ma'am, with our moderator as Dr. Vinay Kumar Gupta sir. Talking about the drug therapy for diabetes mellitus, it can be classified into insulin therapy and GLP-1RA and oral anti-diabetic drugs. Oral anti-diabetic drugs are hypoglycemic medications which are used mainly in the treatment of type 2 DM, whereas insulin therapy and GLP-1RA are injectables mainly used in the treatment of type 1 DM. Insulin therapy is basically the administration of exogenous insulin to supplement or replace endogenous insulin production. The sources of exogenous insulin are beef insulin, porcine insulin. However, they cause allergic and immunogenic responses. Therefore, human insulin, which is prepared from recombinant DNA technology, is used these days instead. Human insulin is less immunogenic, more stable. Insulin analogues are prepared by modifying amino acid sequences of human insulin, which can change its pharmacokinetics. Moving on to types of insulin analogues, we have rapid-acting insulin, rapid-acting inhaled insulin, short-acting, intermediate-acting, long-acting, and ultra-long-acting insulin. Rapid-acting insulin, like Lispro and Aspart, work in 15 minutes and are taken just before a meal. They work for 2 to 4 hours and are frequently used in combination with long-acting insulin. Rapid-acting inhaled insulin works similar to rapid-acting and are often used with injectable long-acting insulin. Regular or short-acting insulin work in 30 minutes and are taken half an hour or an hour before a meal. The duration of action is about 3 to 6 hours. Intermediate-acting insulin such as Lente and NPH work in 2 to 4 hours for about 12 to 18 hours. Therefore, they cover insulin requirements for about half a day or overnight. They are frequently used with rapid and short-acting insulin. Long-acting insulin such as Glargine work in 2 hours for up to 24 hours. They cover insulin requirements for about a day and are used with rapid or short-acting insulin. Ultra-long-acting insulin like Decludic work in 6 hours for about 36 hours to provide consistent insulin over a long period of time. The side effects of this insulin are hypoglycemia, edema and weight gain, allergic reactions, insulin lipoatrophy, insulin lipohypoatrophy. Now moving on to GLP-1 RAs, which are our other injectables used for the treatment of type 1 diabetes mellitus. GLP-1 RA are glucagon-like peptide 1 receptor agonists, which mimic the action of endogenous hormone GLP-1 to decrease insulin resistance, increase satiety and decrease body weight. They act on adipose tissue to decrease resistance and decrease lipolysis, and they act on fatty liver to decrease lipogenesis and increase insulin sensitivity. Examples are exenolide, dulaglutide, liraglutide. The advantages are weight loss, no hypoglycemia, reduced cardiovascular diseases, improve non-alcoholic fatty liver disease, and disadvantages are GI side effects, they require injections, pancreatitis, and thyroid cancer. Now moving on to oral hypoglycemic drugs, which are used in the treatment of type 2 diabetes mellitus. They can be classified into drugs that can either overcome insulin resistance or enhance insulin secretions, or may work through other miscellaneous mechanisms. The drugs that overcome insulin resistance are biguanides and thiazolidinediones. Biguanides like metformin increase hepatic AMP activated protein kinase activity. Thiazolidinediones like pioglitazone are peroxisome proliferator activated receptor gamma agonists. The drugs that enhance insulin secretion are sulfonylureas, meglitinides, DPP-4 inhibitors. Sulfonylureas like glimepiride and glipizide, and meglitinides like rapaglinide and nataglinide are potassium ATP channel blockers. DPP-4 inhibitors like sitagliptin and saxagliptin inhibit the enzyme dipeptidyl peptidase 4 to decrease glucagon release and increase glucose-dependent insulin release. Other miscellaneous drugs are alpha-glucosidase inhibitors like A-cargos and meglitol, which inhibit polysaccharide reabsorption from the GIT, and SGLT2 inhibitors like dapagliflozin and canagliflozin, which inhibit the sodium-glucose co-transporter 2 in proximal tubule and reduce renal glucose absorption. Now moving on to the advantages and disadvantages of the drugs that we have just now discussed. Advantages of metformin are that it is inexpensive, does not cause hypoglycemia, and once a day administration is enough. Disadvantages are GI side effects, B12 deficiency, and rarely lactic acidosis. Advantages of thiazolidinediones are once a day administration, reduced cardiovascular disease, durable effect, do not cause hypoglycemia. Disadvantages are edema, congestive heart failure, weight gain, osteoporosis. Advantages of sulfonylureas are it is inexpensive, rapid acting, and has a long history of use. Disadvantages are hypoglycemia, weight gain, and limited durability. Advantages of meglitinides are they decrease postprandial glucose, have flexible dosing, and are relatively inexpensive. Disadvantages are hypoglycemia, weight gain, and frequent dosing. Advantages of DPP-4 inhibitors are do not cause hypoglycemia, are weight neutral, that is they don't increase weight or decrease weight. They decrease postprandial glucose, and disadvantages are pancreatic disease, heart failure, arthritis. Advantages of SGLT2 inhibitors are weight loss, do not cause hypoglycemia, decrease heart failure, and disadvantages are they cause a lot of urinary tract infections and genital mycotic infections. Advantages of alpha-glucosidase inhibitors are do not cause hypoglycemia, are weight neutral, decrease postprandial glucose, and disadvantages are GI side effects and frequent dosing schedule. Now let us summarize and compare the benefits of the commonly used drugs that we have just now discussed. Metformin, thiazolidinediones, sulfonylureas, meglitinides, and GLP-1 RA are highly effective in reducing glucose. Sulfonylureas and meglitinides cause hypoglycemia. Thiazolidinediones, sulfonylureas, and meglitinides increase body weight. Therefore, they are usually administered to thin patients, and SGLT2 inhibitors and GLP-1 RA decrease body weight, are hence administered to obese patients. Metformin, thiazolidinediones, alpha-glucosidase inhibitors, SGLT2 inhibitors, and GLP-1 RA have a potential benefit on cardiovascular diseases. Thiazolidinediones and DPP-4 inhibitors increase congestive heart failure, and alpha-glucosidase inhibitors SGLT2 inhibitors reduce the progression of renal failure, and GLP-1RA decrease proteinuria. Now, talking about the approach that we have towards diabetes management, type 1 diabetes mellitus is usually managed by giving proper dietary recommendations and insulin. Type 2 diabetes mellitus is controlled by diet, exercise, and metformin unless it is contraindicated in complicated patients. If it is uncontrolled like this, it can be controlled in an uncomplicated or obese patient by giving metformin and any one hypoglycemic drug. If it is still uncontrolled, then metformin can be given with any 2 hypoglycemic drugs. The final resort is to switch over to a combination of insulin, metformin, and any one hypoglycemic drugs. Type 2 diabetes mellitus can be controlled in severe, underweight, complicated patients, pregnant females, or infected patients by giving metformin and insulin. Now moving on to FDA-approved fixed-dose combinations. The examples of this are that there are 4 combinations of bioguanides and DPP-4 inhibitors, 4 combinations of bioguanides and SGLT2 inhibitors, and so on. The basis for this rationality is that the constituent medicines in fixed-dose combinations should act by different mechanisms. Their pharmacokinetics must not vary widely, and their ingredients should not have toxicity supraadditively. Now we have discussed about the drugs that are in their phase 4 of clinical trials, and now we will discuss about the newer drugs in phase 1, 2 or 3 of their clinical trials. Tirzepatide is a dual agonist and causes decrease in HbA1c. Epiglenitide is a GLP-1RA which is given once a week. Inhaled insulin like Afreeza are in phase 3 and 4, and they are ultra-rapid acting inhaled insulin consisting of technosphere insulin powder. Oral insulin like ORMD0801 are in phase 3, and 8 mg of it at bedtime reduced HbA1c and was safe and well tolerated. Lobeglitazone is approved in South Korea and was also found to be safe and effective in the Indian population. Dorsaliatin is a novel dual-acting agent that targets both pancreatic and hepatic glucokinases. MSDC0602K is in phase 3 and acts as a mitochondrial membrane transport protein modulator that increases insulin sensitivity. Now, I would like to call my fellow colleague, Ayushi Bansal, on behalf of the Department of Medicine.
Good morning, respected dignitaries, respected teachers, and my dear colleagues. I am Ayushi Bansal of Final MBBS Part 2, going to present on topic clinical features, complication and management of diabetes mellitus on behalf of Department of General Medicine with my colleagues Indu Sharma, Shivani, Shubham Meena and Rajshri Meena under the guidance of Dr. Puneet Rijwani, Professor and Head, Department of Medicine, and moderator Dr. Pradeep Agarwal, Professor and Unit Head, Department of Medicine. We'll start with clinical features, which include classical triad, which consists of polyphagia, polyripsia, polyuria. Other features include weakness, tiredness, lethargy, fatigue, non-healing ulcers, poor wound healing, foot ulcers, weight gain or weight loss, and blurring of vision. Now we'll see complication of diabetes. It can be acute and chronic. Although diabetes is a chronic disease, it has acute complications as well, which include diabetic ketoacidosis and hyperosmolar hyperglycemic state and hypoglycemia. Pathophysiology of diabetic ketoacidosis. DKA develops usually in type 1 diabetes mellitus, which is absolute deficiency of insulin, when there is stress factor requiring higher dose of insulin or missing dose of insulin. DKA less commonly develops in type 2 diabetes mellitus, which is relative deficiency of insulin when there is associated infections or MI. Patient may develop ketoacidosis, but usually it is mild and easily reversible with insulin therapy. HHS develops in elderly diabetic who are neglected at home or nursing homes, and they have history of poor oral intake or infections. These patients are passing a lot of urine and become severely dehydrated, lead to comatose state. Now, sign and symptoms. Symptoms include malaise, generalized weakness, fatigability, nausea and vomiting, dry mouth, skin, anorexia and weight loss, polyuria, polydipsia, abdominal pain, blurred vision, leg cramps, altered consciousness, missed meditations, poor compliance. Signs consist of ill appearance, dehydration, hypotension, tachycardia, air hunger, cold extremities, decreased reflex, characteristic acetone breath odor, confusion, drowsiness, and signs of infection. Now we'll see difference between DKA and HHS. DKA usually occurs in type 1 diabetes mellitus, where HHS usually occur in type 2 diabetes mellitus. Ketosis is present in DKA and absent in HHS. DKA can occur at any age and HHS typically occurs in elderly. DKA onset is rapid and HHS is insidious in onset. Nausea and vomiting and abdominal pain is present in DKA whereas absent in HHS. Mental changes and focal neurological deficits and seizures are present in HHS where absent in DKA. Pre-renal azotemia is mild in DKA whereas it is marked in HHS. Blood glucose level, which is around 250 to 600 mg per deciliter in DKA and 800 to 1200 mg per deciliter in HHS. Fluid deficit is 3 to 5 liters in DKA and 8 to 10 liters in HHS. Addition of dextrose, which is management therapy, we maintain serum glucose level around 200 mg per deciliter in DKA and 300 mg per deciliter in HHS. Bicarbonate therapy is needed in DKA and not needed in HHS. Mortality rates is around 2 to 5% in DKA and 15% around in HHS. Now we'll see management. First we confirm the diagnosis. Then we assess serum electrolytes, acid-base status, renal function, which is creatinine and urine output. Then we replace fluid by normal saline or ringer lactate. Then administer short-acting regular insulin IV, which is 0.1 unit per kg per hour, then increase to 2 to 3 folds if no response is seen by 2 to 4 hours. Replace potassium if required. Continue above until patient is stable. Glucose goal is around 8.3 to 11.1 millimole per liter and acidosis is resolved. Administer long-acting insulin as soon as patient is eating. Administer sodium bicarbonate if pH is less than 6.9. Now we'll see chronic complications. Chronic complications can be microvascular and macrovascular. First we'll see microvascular complications. Microvascular complication consists of neuropathies, nephropathies and retinopathies. What is the pathophysiology of microvascular disease? When there is hyperglycemia and hyperlipidemia, oxidative stress is generated and hypoxia and advanced glycation end products and receptor for advanced glycation end products leads to inflammatory signaling cascades, which leads to local activation of pro-inflammatory cytokines, then which leads to inflammation, and finally nephropathy, retinopathy and neuropathy occurs. Diabetic retinopathy, leading cause of blindness in age 20 to 74 years. Chances of blindness is more in diabetic patients. It can be of two types, proliferative retinopathy and non-proliferative retinopathy. Proliferative is neovascularization of retinal arteries and macular edema. It causes retinal vascular microaneurysm, blood hemorrhages and cotton wool patches. Non-proliferative includes loss of pericytes, increased retinal vascular permeability, alteration in retinal blood flow. Now what is treatment for a diabetic retinopathy? Prevention, so annual checkup of eye is essential. Intensive control of diabetes, control of BP, laser coagulation, phenofibrinate, prevent retinopathy, which is independent of dyslipidemia and serious events, anti-VEGF drugs therapy. Renal complication, commonly associated with diabetic retinopathy. Retinal vessels are mirrors of status of microvasculature of body. If changes are present in retinal vessels, it means renal and coronary arteries are also affected. These effects may be due to intraglomerular vessel hyperfiltration and increased pressure in glomerular capillaries. Structural changes in glomerulus. Now, initially there is normal GFR, then transient increase in GFR is seen, then it leads to reduced GFR, which leads to end-stage kidney disease. In between, ACR ratio is less than 3 mg per millimole, which is normal albuminuria, then microalbuminuria albuminuria occurs, then macroalbuminuria occurs. Diabetic nephropathy, intensive diabetic control, BP control, dyslipidemia should be treated at ACE inhibitors, ARBs. If BP is not well controlled, then calcium channel blockers or beta blockers or diuretics can be added. Some GLP-1 receptor analogs and SGLT2 inhibitors are effective in glycemic control and reducing progression of CKD due to diabetes. Now, diabetic neuropathy occurs in around 50% of diabetic mellitus type 1 and type 2. It can manifest as diffuse distal symmetric neuropathy in lower limb, or autonomic neuropathy, or mononeuropathy, or radiculopathy, or both myelinated or unmyelinated factors may be affected. What is treatment for diabetic neuropathy? Improve glycemic control, hypertension and dyslipidemia should be treated. Avoid alcohol, tobacco and smoking. Treat nutritional deficiency and give vitamin B12 and folic acid. Educate patient for feed sensation loss and food care. Medicine includes tapentadol, TCAs, SNRI, SSNRI, carbamazepine, gabapentin and maybe trial. Chronic complications include macrovascular, which includes cardiovascular disease, peripheral vascular disease, cerebrovascular disease. Atherosclerosis, narrowing of large blood vessels due to elevated glucose levels. This can lead to heart attack, stroke and poor blood flow due to various organs and tissues. Now we will see about diabetic foot. Its pathophysiology, which includes neuropathy, vascular insufficiency and secondary infection. Neuropathy leads to sensory loss, motor neuron dysfunction and autonomic dysfunction. Vascular insufficiency leads to ischemia, impaired wound healing, and secondary infections leads to inflammation, impaired wound healing and reduced angiogenesis, which all leads to diabetic foot ulceration. Now, diabetic foot ulcer is skin sore with full thickness skin loss on foot due to neuropathic or vascular complication in patient with diabetes. GI and genitourinary complications include delayed gastric emptying, abdominal bloating, anorexia, nausea, vomiting, and early satiety. Altered bowel movements, which is diarrhea or constipation, can occur. Diabetic autonomic neuropathy may lead to cystopathy, which is incomplete evacuation of bladder and failure to sense full bladder. Female sexual dysfunction, dyspareunia, and reduced lubrication. In males, it can lead to erectile dysfunction and retrograde ejaculation. Other complications include dermatological infections, cataract, glaucoma, periodontal disease, hearing loss. Other comorbid conditions associated with diabetes are depression, obstructive sleep apnea, fatty liver disease, hip fracture, osteoporosis, cognitive impairment, or dementia. Now we will see management of diabetes. Management includes 4 components. First, dietary management. Second, lifestyle management, which includes exercise, insulin therapy, and oral hypoglycemic agents, which can be used individually or in combination. What are the goals of diabetic management? First, to achieve and maintain optimal glycemic control, to prevent the onset or delaying the progression of late complication of diabetes, to improve quality of life. Guideline recommended glycemic targets in diabetes. According to ADA, which is American Diabetic Association, HbA1c should be less than 7%, fasting plasma glucose should be 90 to 130 mg per deciliter, and postprandial glucose should be less than 180 mg per deciliter. According to American College of Endocrinology, which is ACE guidelines, HbA1c should be less than 6.5%, FPG should be less than 110 mg per deciliter, and postprandial glucose should be less than 140 mg per deciliter. First, there used to be glycemic triad, which is HbA1c on target, fasting plasma glucose control, and postprandial control. Now, it has converted into composite, which includes less glycemic variability, less hypoglycemia, less weight gain, and better quality of life. Now we have 4 types of insulin which are used in insulin therapy: rapid acting insulin, short acting insulin, intermediate acting, and long acting. Insulin regimens with insulin analogs. There are 3 regimens. First, basal regimen. which involves using glargine once daily at bedtime or determine twice daily, suitable for initiating insulin therapy in type 2 diabetes along with oral hypoglycemic agent. Conventional split dose regimen utilize pre-mix analogs injected twice daily before breakfast and dinner, commonly used in both type 1 and type 2 diabetes. Basal bolus regimen, which is intensive regimen, combines glargine at bedtime for basal insulin needs with short-acting analogs for mealtime coverage, typically used in type 1 diabetes and occasionally in type 2 diabetes. Now, oral anti-diabetic drugs, which has been discussed by Department of Pharmacology. We'll proceed with this chart given by American Association of Clinical Endocrinologists. First, for management, we have to do lifestyle modifications, which include medically assisted weight loss, dietary changes. Now, we'll see HbA1c entry level. If HbA1c is less than 7.5%, we'll start with monotherapy. If A1C is greater than 6.5% in 3 months, then we proceed to dual therapy, or if entry levels of A1C is more than 7.5%, we directly start with dual therapy. If goal is not achieved in 3 months, then we proceed to triple therapy, in which metformin plus 2 other OHA is added. If entry level of A1C is more than 9%, then we start with dual therapy or triple therapy, and if symptoms are present, we start with insulin plus add other OHA agents. What are the take-home points? It's essential for individuals with diabetes to strictly control their blood glucose level to reduce risk of developing or worsening of complications. Regular monitoring, lifestyle modifications, and proper medical management play a crucial role in preventing and managing diabetes-related complications. Remember that both type 1 and type 2 diabetes can lead to these complications. Early detection and proactive care are essential for minimizing their impact on overall health and quality of life. Now I would like to call my colleague Anjali Singh on behalf of Department of Gynecology and Obstetrics.
A very good morning to all the dignitaries present over here. Today, I, Anjali Singh, with my batchmates, Bhavya Saini, Chahat Agrawal, Suhani Goyal and Siddharth Katta, under the guidance of Ma'am, Dr. Usha Shekhawat, Professor and Head of Obst Department, Moderator Ma'am, Dr. Anshul Kulshrestha, Assistant Professor of the Obst Department, would like to discuss about gestational diabetes mellitus. Diabetes in pregnancy could be of two types. If a diabetic woman conceives, we call it as pre-gestational diabetes, and if the carbohydrate intolerance occurs during pregnancy, we call it as gestational diabetes. According to the ACOG 2017 guideline, any degree of glucose intolerance that either commences or first diagnosed in pregnancy is termed as gestational diabetes mellitus. According to WHO, GDM is defined as carbohydrate intolerance with the onset or recognition during the pregnancy. As we all know that pregnancy is a diabetogenic condition and there are certain changes in the pattern of insulin secretion and sensitivity. Like in early pregnancy, we see hypoglycemia because of increased insulin sensitivity and decreased diet of the pregnant woman because of recurrent nausea and vomiting. In mid-second and third trimester, we see hyperglycemia because of progressive increase in insulin resistance. And now the question arises as to why pregnancy is a diabetogenic condition. It is because of increased insulin resistance that is due to increased production of HPL, cortisol, estriol and progesterone, which all have an anti-insulinic action. During, the destruction of insulin by kidney and placenta also contributes to it. Increased lipolysis and gluconeogenesis also contributes to it. The idea about risk factor is to predict the probability of the pregnant woman to develop diabetes during her gestational period, which includes age more than 30 years, obesity, a positive family history of diabetes, previous history of overweight baby, previous GDM, unexplained perinatal loss, presence of polyhydramnios or a recurrent vaginal candidiasis, women with PCOS or hypertension. Diabetes during pregnancy can be classified as pre-gestational or gestational. The criteria to be met to call a diabetes as pre-gestational includes presence of classical diabetic symptoms like excessive thirst, frequent urination, unintentional weight loss, with either the presence of fasting plasma glucose levels more than 126 mg per dl or the 2-hour plasma glucose levels more than 200 mg per dl or the random plasma glucose levels more than 200 mg per dl or the HbA1c levels more than 6.5%. Gestational diabetes is diabetes diagnosed during the pregnancy that is not clearly overt diabetes. Now it is also critical to note the Government of India guidelines for the screening of GDM. Whenever a pregnant woman approaches to the OPD, during her first antenatal visit, we have to test her for the GDM, in which we will give her 75 grams of oral glucose and test for her 2-hour blood sugar values. If it comes more than 140 mg per dl, then the test will be termed positive and we will manage her as a GDM patient. But if the values are less than 140 mg per dl, we will repeat the testing at 24 to 28 weeks. And now if the values come more than 140 mg per dl, we will manage her as a GDM patient. But still, if the values remain less than 140 mg per dl, we will manage her as a normal antenatal patient. Now let's move our focus to the DIPSI criteria, which is followed all over the India, which includes giving the pregnant woman 75 grams of glucose in 100 ml of water, irrespective of the fasting status of her. It has to be taken by her within 5 to 10 minutes. If the vomiting occurs within 30 minutes, then we need to repeat the test next day. But if vomiting occurs after 30 minutes, then we can continue with the test. We have to test for the plasma glucose levels after 2 hours. If the values come more than 200 mg per dl, then we will call her as over-diabetic. But if the values lie between 140 to 200, then we will call her as a GDM patient. Now, the question arises as to how pregnancy affects diabetes. Well, it causes difficulty in stabilizing the blood glucose by altered carbohydrate metabolism and impaired insulin action. Also, there is a renal glycosuria, precipitation of diabetic ketoacidosis, and worsening of vascular changes like retinopathy, nephropathy, and coronary artery disease. What are the effects of diabetes on pregnancy? It can be understood under 3 headings: maternal effects, fetal effects, and neonatal effects. The maternal effects includes effects seen during pregnancy, which are spontaneous abortion, preterm labor, infection, preeclampsia, polyhydramnios, maternal distress, and diabetic retinopathy, nephropathy, and neuropathy. During the labor, the woman can also experience perineal injury, PPH, uterine inertia, prolonged labor, shoulder dystocia, and other kinds of operative interferences. During the puerperium, puerperal sepsis and lactational failure may also be there. And as a long-term complication, type 2 diabetes mellitus and renal and cardiovascular disorders can also occur. The fetal effects are fetal macrosomia, growth restriction, congenital anomalies, chemical imbalances after birth, sudden fetal demise, chronic fetal hypoxia, and a long-term sequelae. As neonatal effects, respiratory distress syndrome, hypoglycemia, hypocalcemia, hyperbilirubinemia, polycythemia, cardiomyopathy, and cognitive developmental errors can occur. Now that we have discussed about the disease, it's time to explore its management. It includes in pre-pregnant state the counseling of women and management of diabetes and other comorbid conditions. During the antenatal period, we need to screen and diagnose for diabetes. And we also have to do surveillance of the mother and fetus. During the labor and delivery, we have to keep a check on the timing and mode of delivery. Also, the intrapartum glycemic management should run hand in hand. As in postnatal period, we have to give medical management for diabetes and other contraceptive advices. The management of GDM constitutes of 3 key features: lifestyle modification, medical nutrition therapy, and pharmacotherapy. Pharmacotherapy includes insulin therapy and oral hypoglycemic agent. Insulin therapy is gold standard as it does not cross the placenta, and oral hypoglycemic agents include metformin and glyburide. The targets for GDM include fasting levels less than 95 mg per dl, 2-hour postprandial blood sugar levels less than 120 mg per dl, and ideal HbA1c levels less than 6%. According to the Ministry of Health and Family Welfare, when a pregnant woman with GDM approaches to the OPD, we have to start her first on MNT and physical exercises. Then after 2 weeks, we will check her 2-hour postprandial blood sugar levels. If it comes less than 120 mg per dl, we can continue with the MNT and physical exercises. But if the values now come more than 120 mg per dl, we have to start her on oral anti-diabetic drugs or insulin therapy. Now when to deliver? If the woman is well controlled on diet, then we have to deliver her between 39 weeks to 40 weeks plus 6 days. But if she is controlled on medication, we can deliver her between 39 weeks to 39 weeks plus 6 days. Although if she is poorly controlled, then we can deliver her between 37 weeks to 38 weeks plus 6 days. Although if there is any kind of abnormal fetal testing, we have to deliver her early, between 34 weeks to 36 weeks plus 6 days. With this, I would like to conclude and call upon the stage Indu Sharma from Department of General Surgery.
Good morning, all the esteemed and revered. Today I, Indu Sharma, stand before you to continue on our discussion of diabetes mellitus by presenting before you the topic diabetic foot disease, as it holds a plethora of clinical importance in today's scenario. I present this before you with the help of my colleagues Hemant Pushkar, Kanika Pillai, Kanak Chaudhary and Anushi Agarwal under the guidance of Dr. Sanjay Singhal Sir, Professor and HOD, Department of General Surgery, and under the moderation of Dr. Akhilesh Suklecha Sir, Professor, Department of General Surgery. To begin with, the contents of the presentation are defining the diabetic foot disease, its pathophysiology, staging and management. Defining the diabetic foot disease. It is known as the infection, ulceration or destruction of tissue of the foot in lower extremity of a person with diabetes. It comes with the etiological triad of neuropathy, vasculopathy and immunopathy. Pathophysiology. As a patient of diabetes mellitus has persistent hyperglycemia, they undergo major 3 mechanisms to develop this disease. First, diabetic neuropathy. It includes sensory, motor and autonomic neuropathy leading to loss of sensitivity, foot deformity and dry skin respectively. In peripheral artery disease, there are 2 major mechanisms, macroangiopathy or microangiopathy, leading to atherosclerosis or microcirculatory disorders respectively, together making an impaired angiogenesis. An infection. There's impaired inflammatory cell function by making it abnormal for the bacterial lethality and neutrophils and macrophages to perform their function. Further, learning the staging. Staging according to Meggitt and Wagner classification, it is divided into 5 grades. In grade 0, there is no open lesion. In grade 1, there is superficial ulceration developing into a deeper ulcer in grade 2, involving the bones and other tissues causing abscess and osteitis in grade 3, causing gangrene of the forefoot in grade 4 and involving the entire forefoot in grade 5. Further, management of diabetic foot ulcer. It can be done in various modalities like managing it medically by the oral hypoglycemic drugs and educating the patient, managing the pain and adequate vascular perfusion. And according to classification, in grade 0 and 1, when there is only a risk or a superficialized ulcer, the major management is medical, where we go for prevention and antibiotics and glycemic control. In the further grades, the surgical management comes into play and includes debridements and amputation. Surgical management of diabetic foot. It includes majorly 3 modalities: debridement, amputation and prosthesis. Debridement. It is the process of removing dead, contaminated or adherent tissue and foreign material from a wound. And it is done by 5 primary methods, namely mechanical, enzymatic, sharp, autolytic or biological. Mechanical debridement. It is done by the use of some outside force to remove dead tissue and can be done by wound irrigation or wet to dry gauze dressing. Enzymatic debridement. It is a safer and easy to perform option. Here enzymes are used as an effective wound surface cleaning agent that accelerate degeneration and debridement. Sharp debridement, it is the most commonly performed modality, and it is performed either one time or sequentially by the use of scalpel or any other sharp instruments. It is rapid and effective. Further, we have autolytic debridement, in which there is body's own mechanism which removes the non-viable tissue. In biological debridement, there is use of medical grade green bottle fly or larva which help in debridement therapy. Coming over to next modality, amputation. It is the surgical removal of all or a part of limb or the affected extremity. It is done in cases when the limb is dead, as in case of gangrene, when it's deadly, as in case of arteriovenous fistula or malignancies, or when there is a dead loss, in cases of paralysis, severe rest pain, trauma and contractures. Further, we have types of amputations, mainly two, open and closed. Closed amputation is an elective procedure, and after amputation, the soft tissues are closed primarily over the bony stump. Example, above knee or below knee amputation. Open amputation or guillotine apparatus. Unlike closed amputation, it is an emergency procedure. That is, it is done in life-threatening infections and crush injuries. And after amputation, the wound is rather left open. There are two types of open amputation, one with inverted skin flap and the other is circular. Learning the levels of amputation. The first, raise amputation. Second, transmetatarsal or Gillies amputation. Tarsometatarsal or Lisfranc amputation. Mid-tarsal or Chopard's amputation. Sines amputation. Below knee or Burgess amputation. Transcondylar or famously known Gritty-Stokes amputation. And above knee amputation. Moving on to complications of amputations, there can be many, such as formation of a painful adhesive scar, deformity inflection, hyperesthesia, edema and pain of the stump, and infection and necrosis. Prosthesis. It is one of the last modalities. Prostheses are used to replace a missing limb or restore and provide the function. They are manufactured by a prosthetist and fit custom-made basis on the patient. Ideally, a prosthesis must perform its function, be easy to maintain, don and doff, be comfortable to wear, preferably should be light in weight, durable and cosmetic to look at. Classification of prosthesis, it is mainly of two types, exoskeleton or endoskeleton. In an exoskeleton, there is an outer laminated shell which helps to transmit the body weight. And in an endoskeleton, there is a pylon made of metal or carbon fiber which is light and provides weight bearing. Ankle foot assembly, it has many types like Jaipur foot, mid-Ross foot, sack, spring-light foot, Seattle foot, quantum foot, true step and proprio foot. Knowing about the famous Jaipur foot. The Jaipur foot is also known as the Jaipur leg. It is a rubber-based prosthetic leg for people with below-knee amputation. Its variable applicability and cost efficiency makes it an acceptable choice for prosthesis. Ramchandra Sharma designed and developed it in 1968. It is a foot piece of same contour as a human foot with fingers. It can be used by people who belong to rural backgrounds. And even it has a wide range of motion such as plantar flexion, dorsiflexion, inversion, eversion, and also helps in crossed leg position. Materials required for Jaipur foot are ordinarily available and are MCR or microcellular rubber, rubber cushion, skin colored rubber, dyes and a stationary anchor. Advantages of Jaipur foot. It does not require shoes and has a certain degree of cosmetic appearance. It permits certain degree of transverse rotation to facilitate the gait of the amputee. It is easily available and cheap and made up of waterproof material. The raw materials, as we saw, are easily available and in appearance it mimics a real foot. Thank you. Now I'd like to call upon Dr. Vineeta Bansal ma'am to enlighten us.
Thank you, Dr. Indu. Good morning, respected dignitaries, all dear colleagues and students. The primary goal of dietary management of diabetes includes maintenance of blood glucose levels into normal range without ceasing pleasure of eating. Specific objectives are to achieve and maintain ideal body weight, to delay or prevent diabetes-related complications, to provide a more practical diet plan with variety of food choices with more emphasis on carb count, count and portion size. So medical nutrition therapy for diabetes includes deriving nutritional needs for patients, as type 1 diabetes is majorly seen in children, so their calorie needs are calculated as shown in the table. For type 2 diabetes, that is mostly seen in adults, calories are given as per American Diabetic Association 2018 recommendations. According to that, 1500 to 1800 calories are given for men and 1200 to 1500 calories are provided for women. Carbohydrate, here quality is more important over quantity. Around 50 to 55% of total calories should come from carbs, complex carbs in form of millets, whole grains, whole pulses, beans, fruits and vegetables, proteins, fresh coconuts, sweet corn, etc. While refined sugars are totally avoided, like sugar, honey, jaggery, juices, sweets, chocolates, ice creams, cold drinks, etc. Here we need to educate our patients for carb counting, glycemic index and Q counting, glycemic load, etc. Glycemic index is the effect of any food on blood glucose levels. It is calculated as area under the glucose response curve of test food divided by area under the glucose response curve of reference food. It is scored in the range of 1 to 100. 70 and above is considered high glycemic index and 55 and below is considered low. Glycemic load. The glycemic response to any ingested food not only depends on glycemic index but also on the total available carbohydrate consumed. Therefore, glycemic load is calculated as glycemic index multiplied by available carbohydrate divided by 100. It is classified into 3 groups. 10 and below is considered low and 20 and above is considered high. Patient is educated for carb counting that provides a more accurate guess for amount of carbohydrate consumed. By this, a person knows amount of blood sugar levels to be increased after a meal or snack, and this provides more freedom to consume variety of food choices, as dose of insulin can be set as per the amounts of carbs consumed. It can be done using food exchange list. One carbohydrate count is 10 to 15 grams that can be provided from different amounts of various foodstuffs. For example, 15 grams of carbs can be achieved from 120 grams of apple or 180 grams of oranges or half cup of oats or half cup of corns and so on. Now carbohydrate distribution across meals. Depending on the type of insulin prescribed, mid-meal and bedtime snack may or may not be necessary. For example, if patient is on a combination of long-acting and rapid-acting analog insulin, a mid-meal and a bedtime snack is not necessary. If a patient is on conventional premise insulin or regular insulin before meals and intermediate acting insulin pre-dinner, a mid-meal and bedtime snack is necessary. This is dose adjustment for normal eating, also known as Dietary. It is a good method for type 1 diabetes, that is, it provides more freedom or more food choices to eat without spike in blood glucose levels. In this, patient knows amount of carbohydrate covered by 1 unit of insulin. Therefore, dose of insulin can be set on the basis of amount of carbs consumed. In case of regular acting insulin, rule of 450 is followed. That is, 450 is divided by total daily dose of insulin. That will be the amount of glucose that will be covered by 1 unit of insulin. Similarly, insulin sensitivity factor is calculated. This is the dose of insulin required to bring down high glucose levels into normal range. There are rules of 1700 for rapid acting and 1500 for regular acting insulins. In this, for example, 1700 is divided by total insulin daily dose, that will be milligram per dl of glucose, that will be bring down into normal range by 1 unit of insulin. Other nutrients. Protein should be provided at least 20% of total calories in form of peas, beans, legumes, dry fruits, low-fat dairy products, egg white or lean meat. Protein and fat, if consumed in large amounts, can slow down breakdown of carbs, as fat delays gastric emptying time. So it doesn't cause immediate spike in blood glucose levels. Fat protein unit is equals to 100 kilocalories from fat or protein. It requires same amount of insulin as is required for 10 grams of carbohydrate. Food insulin index, it ranks food on the basis of their physiological insulin demand and measures postprandial increase in insulin secretion of a whole food. Micronutrients, there is no specific evidence on use of multivitamin supplements, multimineral supplements for diabetics, but if patient is pregnant or lactating or on a very low calorie diet, then supplementation may be required. And if patient is hypertensive, then of course we need to restrict sodium in the range of 2 to 3 grams per day. Here is a list of artificial sweeteners that are approved by FDA, Food and Drug Administration. within a limited amount, but practically we never recommend any artificial sweetener to any patient, as these are consumed just for taste without any health benefit. And also there are some researches that show their carcinogenic effect after long-term usage. GDM. The goal of nutritional management in GDM includes to maintain blood glucose levels into normal range with achieving optimum fetal growth and desirable maternal weight gain. So 30 kilocalories per kg desirable body weight in first trimester with additional 300 kilocalories per day in second and third trimester are recommended. Minimum carbohydrates should be provided at least 175 grams with 20 to 30 grams of fiber. Protein should be 10 grams additional to the normal RDAs for adult female. Remaining percentage of calories should come from fat. So key guidelines to achieve glycemic control is to provide 500 to 700 calories less than normal requirements. Prefer low glycemic index, low glycemic load food, low saturated fat should be consumed, and increase fiber and rich carbs, lean protein. Avoid refined carbs, roots and tubers. Prefer omega-3 fatty acid rich foods over cream or fried foods, and read nutrition label carefully. I would invite Dr. Pracchi to proceed further. Thank you.
Thank you, ma'am. A very good morning, respected dignitaries, teachers, and my dear colleagues. I, Pracchi Chauhann, on behalf of my team members, Sahajpreet Singh, Tanush Gupta, Indu Sharma, and Piyush Tiwari, stand before you to present on the topic Diabetes Mellitus, focusing on the National Program for Non-Communicable Diseases. I thank Dr. Rajat Vora sir for his guidance and Dr. Shweta Mangal ma'am for her moderation. This program was formerly known as the National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Diseases and Stroke. However, the logo for the program remains the same. As per World Health Organization, non-communicable diseases are chronic diseases of long duration that result from a combination of genetic, physiological, environmental, and behavioral factors. The burden of non-communicable diseases is so much so that they are responsible for 74% of all deaths worldwide. Yes, you heard that right. And diabetes contributes to 3% of those deaths. Here is a timeline of the program that evolved from 1987 to current day. The path-breaking National Diabetes Control Program was launched in the year 1987. It was followed by developments in the form of pilot phases. Then finally, in the year 2013, it was integrated with the National Health Mission and came about to be known as the National Program for Control and Prevention of Cancer, Diabetes, Cardiovascular Diseases and Stroke. It gained pace and applaud following the establishment of district NCD cells and clinics, and in the landmark year 2023, it was announced as the National Program for Non-Communicable Diseases that included newer additions like the chronic obstructive pulmonary disease, chronic kidney disease, non-alcoholic fatty liver disease, and ST elevation myocardial infarction. Following are some objectives of the NP-NCD. They are health promotion through behavior change, screening, early diagnosis, management, referral and follow-up, strengthening the supply chain, building capacity of the healthcare providers, monitoring, supervision and evaluation of the program, followed by coordination and collaboration with other programs under different ministries. There are some strategies that are devised to achieve the aforementioned objectives. They are as follows: health promotion, awareness generation and promotion of a healthy lifestyle, early diagnosis through screening, timely, affordable and accurate diagnosis, access to affordable treatment, supervision, monitoring and evaluation, and lastly, rehabilitation. The World Health Organization has proposed a set of 9 voluntary global NCD targets for the year 2025. These targets are combined under 3 major categories that focus on mortality and morbidity, risk factor for NCDs, and national systems responses. On screen, you can see the organizational structure of the NP-NCD. At the level of sub-center, we have the Village Health Committee, which is the primary touchpoint between people and the healthcare services in rural India. We can see opportunistic screening being performed there, health promotion and referral of complex cases. Moving on to Block CHC, that has NCD clinics. Early diagnosis and management is done, followed by laboratory investigations. Moving on to a more higher and advanced center, which is the district hospital, we see cardiac care units, cancer unit facilities being provided. Now the most advanced of all, the tertiary level, where cancer care facility is provided. The components of NP-NCDs are as follows. Number 1, health promotion for the general population. Number 2, disease prevention for high risk. Number 3, assessment of prevalence of risk factors. On screen you can see a table which depicts the package of services provided by the requisite health facility. Health promotion for behavior change seems to be a common facility that is provided at every center. Starting off with the sub-center, which is the primary touchpoint again, we can see opportunistic screening being performed. Strict method to evaluate the blood glucose is also seen, and referral of suspected cases to higher centers is also seen. Moving on to PHC and CHC, where early diagnosis through clinical and laboratory investigations is performed, and common lab investigations such as blood sugar is also seen. Moving on to district hospital, where more advanced investigations are performed such as kidney function tests, the lipid profile evaluation. Intensive care is also provided, and referral of difficult cases to higher centers is done. The most advanced of all, the tertiary care centers, where in addition to the above services, we see comprehensive cancer care including prevention, early detection, diagnosis, treatment, minimal access surgery, aftercare, palliative care and rehabilitation services that are being provided. On screen you can see an NCD clinic where free screening and testing is done for non-communicable diseases. Moving on to population-based screening, it is defined as a strategic screening which is done on the target population in a systemic manner. The data for population-based screening comes from three sources. Number 1, National NCD Portal. Number 2, Clinical Decision Support System, the CDSS Integrated Patient Pathway. Number 3, the Ayushman Bharat Health and Wellness Center Portal. We start off with the National NCD Portal. It has a suite of 6 applications. At the level of village, we have the 8-credited social health activist, commonly known as ASHA, who has the job of population enumeration and risk assessment on the ASHA app. At the level of sub-center, we have an auxiliary nurse or midwife. They do NCD screenings and follow-ups. At the level of PHC, we have a medical officer or nurse who manage simple NCD cases. At the level of district hospital, we have a specialized nurse who manages complex NCD cases. Finally, we have the admin who manages users and facility accounts. And lastly, the program officials who are responsible for monitoring program performance. Moving on to the Clinical Decision Support System, the CDSS Integrated Pathway. A patient arrives and the ASHA fills the community-based assessment checklist form and enrolls the patient. Then the nurse is responsible for entering the initial assessment and examination details onto the nurse portal. Then a print is taken out for the recommended action for the medical officer. Then it's up to the medical officer whether to accept the recommendation or rewrite the prescription. Then the nurse updates the patient record on the nurse app after the medical officer has made their decision, and the patient walks out with the prescription. Moving on to the Ayushman Bharat Health and Wellness Center portal. It was recently renamed as the Ayushman Arogya Mandir by the Union Health Ministry in November 2023. This portal provides with the following data state-wise: proposed, progressive and operational health and wellness centers, human resources, training, medicine and diagnostics, and service delivery such as footfalls, persons who are screened for diabetes mellitus, and the person who has received the requisite treatment for the same. Following are the key components of the Ayushman Bharat Health and Wellness Center portal: expanded service delivery, expanding the human resource and multi-skilling, building partnerships for knowledge and implementation, community mobilization and promotion of health, building a robust IT system, financing and providing payment reforms, providing medicines and expanding diagnostics, and building a continuum of care for easing referrals. On screen, you can see some indicators for monitoring and evaluation of the said program, We start off with the input indicators. They are infrastructure and human resources, which play a major role in evaluating the efficiency of the program. Then process indicators include infrastructure, training, advocacy and communication, and IT system usage. Then lastly, output indicators include enrollment and number of ABHA ID creations, screening, and outcome in incidents. Thank you so much.
Controls the blood sugar levels.
Let everybody knows. I want to know action. ये ग्लूकोज को सेल के अंदर डालता है, बाहर डालता है, क्या करता है, कैसे फैसिलिटेट करता है? Anybody can answer that? Okay.
So glucose in the blood is taken up by the GLUT receptors in the beta cells, and then in the cell.
Which type of receptors there?
GLUT receptors.
Which type of receptors there?
GLUT receptors.
Okay.
And then in the cell, it gets converted into ATP, and then ATP acts on the ATP-dependent potassium channels and they block those potassium channels. So there is depolarization of the cell, because of which insulin is released in the blood, which decreases the blood glucose level.
Which drug is the most important drug in management of diabetes? No. Clinical side का कौन सा है? Final MBBS कौन सा है? आप look.
Metformin.
Excellent. What is the mechanism of action of metformin?
So it is a white one, right?
The mechanism of action of metformin. यहाँ तो उनके पास है. Anybody from you? Basic पूछ रहा हूँ बेटा. Have you heard about peripheral utilization of the glucose? That is the most important thing for the metformin. It is the peripheral utilization of the glucose, and that is responsible for not producing hypoglycemia. It is wonder drug. It is one of the wonder drugs. There are few wonder drugs in the medicine, and this drug is wonder drug, which you can use as alone or in combination. ठीक है? Gynecology से कौन सा फाइनल MBBS आप हैं? आपने प्रेजेंट किया था. How will you differentiate? When will you screen for diabetes if a pregnant patients come to hospital?
So we will screen in first antenatal visit whenever she approaches for the first time to the OPD.
What is the difference in American or European guidelines of screening and Government of India guidelines of screening in diabetes?
Sir, actually, Asia and India being a country where it is itself a risk factor for diabetes.
Yes, this is what I want to emphasize on all, that we Indians or the colored people, correct, so-called, other than white, we are not white people, we are more prone for diabetes as a rule. So we should screen all patients, all pregnant ladies who are coming. In the America, in the Europe, unless there are risk factor for diabetes, they will do on the first visit. Otherwise, routinely they do around 5 to 6 months, 24 weeks of pregnancy. That is the reason. So you should do at the first visit. What will be the findings at first visit when you will say that it is not a gestational diabetes or it is a gestational diabetes?
So blood glucose levels
कितना होना चाहिए?
Sir, it should be less than 140 postprandial.
What about the fasting?
So fasting should be less than 120.
Is it recommended to do one step or two step?
Sir, GCT is done in 2 steps.
No, screening should be done in one step in Indian setup or 2 steps in Indian setup? One step. So what is that one step?
So we will give 75 grams of glucose in 100 ml of water, and then we'll check for 2 hour postprandial blood sugar levels, and that comes.
थोड़ा पास में रखो, माइक मुंह के पास में रखो बेटा.
Then after 2 hours we will check for the blood sugar values. If it comes less than 140, then it will be said to be a normal patient.
Can you explain me the carbohydrate metabolism in the pregnancy? Why there is a weight gain in the first and second trimester of pregnancy?
Sir, because there is increased lipolysis.
Please keep silent and listen to it.
Sir, it is production of free fatty acid and lipolysis increases to provide.
Why the production of free acids are required? This is what I want to know. You are giving excellent answers. I want to know that. Why there is deposition of fat in the first and second trimester during pregnancy?
Sir, to provide more and more nutrition to the fetus.
So glucose has to be spared for the fetus.
Yes, sir.
Alright. So mother can utilize the free fatty acids for her own energy requirement and giving preference to her baby or her fetus. Alright. That is the reason. So that is why in the first and second trimester there is a fat deposition. In the third trimester or the last trimester there is a lipolysis, production of the tissue. What are the complications of gestational diabetes? How will you differentiate with, suppose एक patient आ गया आपके पास, आपने एंटीनेटल पे उसको चेक किया, how will you differentiate that it is a gestational diabetes or over diabetic, that patient was diabetic before and she has never gone for the blood sugar test?
Sir, it will be by the values of blood sugar. If the blood sugar values come more than 140, then it will be over diabetic. But if the values lie between 120 to 140, then we will call it as GDM patient.
Okay, and if you give the glucose test then? Tolerance test?
Yes, sir, then the more than 200, sir.
More than 200. वो जीटीटी करा नहीं पा रहे, उसको हाइपरएमेसिस ग्रेविडियम है, आप उसको 75 मिलीग्राम ग्लूकोज देते हो, उसको बार वॉमिटिंग हो जाती है. How will you confirm that this patient is over diabetic or it is gestational diabetes? वो नहीं टॉलरेट कर पा रही है, ऑलरेडी प्रेगनेंसी में फर्स्ट ट्राइमेस्टर में वॉमिटिंग वगैरह होती है, नौसिया होता है, आपने दिया 10 मिनट तक वेट किया, 10 मिनट में देते हो ना, फिर उसको वॉमिटिंग हो गई, नौसिया हो गई, वो टॉलरेट नहीं कर पा रही है.
Check the HbA1c.
Yes. So what should be the HbA1c?
Sir, less than 6.5.
So remember it that if the patient is not able to tolerate the GTT, then you can do the screening with the HbA1c plus sugar levels. Alright. Excellent. एक मैं रिक्वेस्ट करूँगा डॉक्टर मेजर जनरल जायसवाल जी से कि प्रेजेंटेशन का जो प्रेजेंटेशन किया बहुत अच्छा किया है, पर स्टिल इट इज लैकिंग. बहुत ज़्यादा ओवर क्राउडेड प्रेजेंटेशन है. तो जैसे अब CCR में होता है सर, तो आप डॉक्टर तरुण ओझा जी काइंडली टेक गाइडेंस फ्रॉम दी डॉक्टर जायसवाल, मेजर जनरल जायसवाल टू प्रेजेंट. सो इट शुड बी क्राउडेड प्रेजेंटेशन था. इस तरह से प्रेजेंटेशन थोड़ा सा अवॉइड करेंगे तो थोड़ा ज़्यादा बेटर रहेगा, लोगों की समझ में भी आएगा, तो इधर से जो मर्मरिंग होती है वो कम हो जाएगी लोगों की, क्योंकि पूरी स्लाइड भरी रहती है, पता नहीं लगता है. ठीक है.
I think hats off to all of you for doing a lovely presentation. I mean, it's absolutely at par with any other professional presentation, the confidence level and the flow of presentation. Having said that, for all those who have been murmuring at the back, I think I'll request the principal, sir, to take a decision that attendance for this UGCR will be mandatory, and those who mark their attendance over here will be given evaluation for internal assessment. Only for those who are present over here, those who are absent will be marked as 0 for that part of the UGCR internal assessment over here. So remember, today the internal assessment plays a very important role in your marking pattern. So if you are going to lose these marks over there, it's your baby at that point of time. Why topics like these are important today? Because India has moved from a phase of communicable disease to the non-communicable disease. There was a time जब मैं कहता था भारत का रहने वाला हूँ, भारत के गीत सुनाता हूँ, tuberculosis, poxes and all that stuff. But today we move towards the non-communicable diseases, and unfortunately हमें gold medal नहीं मिला इस बार ओलंपिक में, लेकिन gold medal in diabetes, India is the diabetic capital of the world with 36% of our population coming in for the diabetic or the pre-diabetic. And apart from that, what aids to this is the obesity, which starts right from the childhood. So the genetic predisposition, obesity in childhood are the ones which contribute to a lot of issues which come over here. We have a silent killer, diabetes, hypertension, liver disease. These are silent killers which may not have any symptoms. And that is why the screening part of diabetes becomes very important.
Hypertension is silent killer and diabetes is sweet killer.
Sweet killers, yes. So, wo mithi churi se kiya halal. So we need to just work on these issues very importantly. Apart from that, the depression and the psychological issues are also a very important non-communicable disease today. But I think full credit goes to all of you and your guides for having created what you have created. What Dr. Swankar sir has said, too much of overcrowding tends to make Jack a dull boy at times. So we need to just work on that when we are presenting. Presenting should not be just reading, it should also be presenting as an extempore skill. And that also you need to develop. The reason why we are organizing the UGCRs is so that you are confident to present anything in front of a population and in front of the public. And such slide presentation, when you make it into a non-reading slide, would probably have a better presentation. But congratulations to everyone.